Hello for the last time. Oh my gosh, you guys, you did it. Well, not quite, I guess. Almost. If you can make it through this last one, you'll have done it. Our final lecture for this course today, we will be looking at the pharynx, we'll look at the larynx, we'll look at the middle and inner ear, and then we'll be done. Some of this lecture today will go over some optional dissections that you can do through the petrous portion of the temporal bone to see if we can identify some of the middle and inner ear structures, but that will be optional. Won't be testing on those on the bodies that you're dissecting, but we might look at some of those structures on models for the practical exam. Let's start by reviewing the pharynx. Remember, the pharynx is just this long tube in the back of the throat here. There's a portion in the back of the nasal cavity. We call that the nasopharynx. There's a portion in the back of the oral cavity. We call that the oral pharynx. And then there's this portion behind the larynx that we call the laryngopharynx. Here, so you can actually see how the larynx opens up to the trachea in front. Down in front here. So the pharynx will go forward into the larynx, which will go down into the trachea. The bottom part of the pharynx is just continuous with the esophagus coming down here. So when people say, if you swallowed something and it went down the wrong pipe, you know how you'll cough a lot coming down this way. If food or drink, usually it's drink, will come down. Sometimes it will enter into the glottis here, the proximal part of the larynx. Sometimes it will get past the vocal cords, and now you've got a really severe cough if it gets down into this area of the larynx, this inferior portion, before it gets down into the trachea. Your body does a very good job at defending itself and really trying to cough and get rid of, expel material that might have found its way into the larynx. But typically what will happen is food and drink will come down into the esophagus, which is just immediately posterior to the larynx and the trachea. Okay, we've seen these structures already, but let's just look at here's a picture particularly of the larynx itself. This is where phonation is produced. There's multiple cartilages that we're going to talk about here, so let's just dig right into these cartilages. The thyroid cartilage, you've seen this before. This is from a front view here, the anterior view. Here's a posterior view looking at the thyroid cartilage from behind. Here you can see it in kind of a lateral view and a kind of a mid cross section or sagittal view. So you can see the thyroid cartilage is here. This is the also called the laryngeal prominence or the Adam's apple. Larger in males. It grows with testosterone, so that's why it's a little larger in males. I liked that old Friends episode when Joey called it his Joey's apple. He just thought that it was named for whoever owned it, so mine would be Jeff's apple, but that laryngeal prominence or the thyroid cartilage is just a universal name for it. It's the largest of the cartilage structures of the larynx. It makes up the majority of the anterior wall of the larynx. Here you can see a cross section. Here's that thyroid cartilage, makes up the majority of the anterior wall. The only other part of that anterior wall of the larynx is part of this cricoid cartilage, which is the next one here. This makes up the majority of the posterior portion of the larynx, which is just below the thyroid cartilage here. There's that median cricothyroid ligament, which is right here between here's again an anterior view. Excuse me, something went down the wrong pipe there. Here's the anterior view, the cricoid cartilage and the thyroid cartilage. Here's that median cricothyroid ligament. This is where you would cut to do a emergency tracheostomy. Hopefully you never need to do that, but that's where that would be, to place that tube so that somebody can breathe. So you can see where that would be. It'd be below the vocal folds. The vocal folds would be a little higher than this. The vocal ligaments here, the vocal cord, and above the cricoid cartilage. So you can see where that would go right into the airway, not up into the portion of the larynx that's going to be producing phonation. Now the back side, just right above here, you can see the cricoid cartilage taken out of its, just taken out of place here. On the back side, the posterior superior edges of the cricoid cartilage are these two cartilages called arytenoid cartilages. these will kind of twist and spin here. There's muscles. We'll see in the next couple slides here. There's muscles called transverse and oblique arytenoid musculature that attaches to these, and these when they contract, along with other musculature that will help pull on these, they'll start to rotate those arytenoid cartilages, and they'll tighten or loosen the vocal cords. So you can see here in cross section, the cricoid cartilage, arytenoid cartilages are right up on top here, and that's going to go from the arytenoid cartilages to the thyroid cartilage is that vocal ligament for phonation. So as these rotate, you'll either tighten or loosen those vocal ligaments there. Let's see, on the top of that, you can see just in the peaks here, they look like little candy corns. So that's how I remember these, the corniculate cartilages. I don't know if that will help you or not, but they sit right on top of the arytenoid cartilages. These are really landmarks. I don't know if I've got a, well, here's another one here, another shot of this. So as you're going to do an intubation, some of you will do this in your careers. These are good landmarks that you'll find for intubation, that you know you're going into the airway. Okay. Now in the walls, so here would be those corniculate cartilages right here. These labeled on this diagram as the corniculate tubercles, but that's just because there's soft tissue over the top of it. So here's the corniculates that are right on top of the arytenoid cartilages, and then lateral to those are these cuneiform cartilages here, and these are found within the membrane of the thyroarytenoid muscle that we'll see in just a little bit here. Here it is right there, but they're kind of found in that membrane around that lateral to the corniculate cartilages here. So these are also landmarks. You'll find these 4 bumps here, those cartilages, and that's how that's where I would point your attention to as you're doing that intubation, is the back wall here, so you can see that. Okay, and then the epiglottis. Let's go back to this. This is, again, just more cartilage. Here's the epiglottis covering from the front side here, lifting up so that anything from the laryngopharynx that's just air can come down into the larynx, and because of the epiglottis being open. So epi, remember, means over, and glottis is the proximal portion of the larynx above the vocal ligaments here. So the epiglottis is going to close. It's going to, when you swallow, part of what happens here is the trachea and the larynx move up. So it's going to move up and underneath the hyoid bone during swallowing. We talked about some of the musculature that will help do that. So this is going to actually close this opening to the glottis with swallowing. Muscle contraction in this area around the vocal cords is usually, and the muscles that we're going to see in a little bit here, it's usually enough to kind of close down that area anyway, to not allow things to come in. But this epiglottis really kind of is a lid that will help kind of seal it all up. Just as an aside, I don't know if this is interesting or not, but nerve gas, which is sometimes used in warfare, really horrific, awful type of warfare, what that sometimes can do is designed to constrict the musculature around the airway so that you suffocate. So there is musculature in here anyway that you'll be able to identify, some of it anyway, and what's that nerve gas can do is just kind of really contract those muscles and not let them relax so that no air can exchange through there. But let's stop talking about warfare tactics. The vocal ligaments, you can see here just above the cricothyroid, let's see, the vocal ligaments right here, coming from the arytenoid cartilage to the thyroid cartilage. So just above the cricothyroid ligament, which we'll see in a little bit here. These will tighten and loosen, so these vocal cords will tighten and loosen as those arytenoid cartilages spin and pivot and rotate for vocalization. Let's now look at some of the musculature that we'll be able to identify. So we'll be able to identify some of this here. Let's start with the posterior side here. The posterior cricoarytenoid muscles right here on each side. This is a posterior view. From the cricoid cartilage to the arytenoid cartilages. These will help to turn the arytenoid cartilages as they pivot, and that will help to tighten the vocal ligaments. these posterior cricoarytenoid muscles here. Just above that, you can see the transverse and the oblique arytenoid muscles right here. So kind of spanning the distance between the arytenoid cartilages on either side. These will help to close the glottis by rotating the arytenoid cartilages together. Here you can see where they are. This is kind of a transverse section here. Anterior, posterior. Here you can see the transverse and the oblique. Can't really see the fiber orientation very well here, but they're going to help pull those arytenoid cartilages together to close off the glottis. The cricothyroid muscle here is on the outside. This is, again, here's anterior and posterior. Here's a lateral view from the right side. This is the only muscle right here that, remember, we learned the superior laryngeal nerve has two branches, the internal and the external branch. This is the only muscle innervated by the external branch. So it helps to pull the thyroid cartilage forward, kind of cocking that forward, which does tighten the vocal cords a bit. The other nerve we talked about, the recurrent laryngeal nerve coming up, that's really going to be what innervates the rest of these muscles. But so if that's damaged, the only one that you'd have left to speak with for phonation would be this, the external branch of the superior laryngeal nerve off of vagus nerve, which will innervate the cricothyroid just to cock that forward a little bit. So you do get some phonation there, but it's not very fun to listen to. Like I said before, it's kind of like, I shouldn't say it's not fun to listen to. Not that listening to anything needs to be fun, but it doesn't give a nice timbre and pitch and tone. It lacks a lot of the other vocalization things that we attribute to speech. Okay, deep to that now. So here's that cricothyroid. Now deep to that, you can see a little bit of it here is going to be the lateral cricoarytenoid cartilage, from the cricoid cartilage up to the arytenoids. This is buried deep to the cricothyroid, as well as the thyroarytenoid, from the thyroid cartilage to the arytenoid cartilages here. So these, the lateral cricoarytenoid muscle here is going to be also help to kind of rotate those arytenoid cartilages. And then the thyroarytenoid is going to help to kind of pull them closer together, the thyroid and the arytenoids, to shorten the cords. So opposite of pulling the thyroid forward, this is going to help pull the thyroid back, kind of shortening them up a little bit. Just now inside of this, so here's thyroarytenoid. Just medial to that is going to be another muscle called the vocalis. And this is going to be, so here, looking at it again from the superior view, a transverse section here. Here would be the thyroarytenoid, from the thyroid cartilage to the arytenoid, and then just medial to that is going to be a muscle here called the vocalis. This is going to be just lateral to the vocal ligaments on each side. This is going to help to tighten the cords and influence the vibration when air comes rushing past here. And then the thyroepiglottic muscle here. This is going to be, again, from the thyroid cartilage up to the epiglottis, and this is going to help to open the glottis during by pulling the epiglottis open. So it's going to open that up. So you can see how it would come from the front to the towards the epiglottis, opening the glottis, lifting the epiglottis off of its lid there. So what you'll likely see in this dissection here are the posterior cricoarytenoid, posterior cricoarytenoid muscles here. You'll also probably see the transverse and oblique fibers of the arytenoid musculature, and you'll also see, you should be able to see the cricothyroid muscle from the cricoid cartilage to the thyroid cartilage here on the front. So these on the back and this kind of on the front lateral side on each. But the other muscles that we just talked about are going to be a little more difficult to identify in this dissection particularly. Now, if I go to a different view here, this is a coronal section. So this, we've seen this slide. We'll come back to this in a second here. Here's a mid-sagittal section. Here is a coronal section. So it's a little bit different. We're looking from back towards the front of the larynx here. And there's an area right above the vocal folds here, which we'll see in just a second, called the vestibule. This is really the glottis. So the epiglottis is covering this opening to the larynx here. So this area right up on top we'll call the vestibule. So just above the vocal folds here and under the epiglottis. And this has receptors in it in the epithelium here for contacting. They'll for contact for anything other than air or a small amount of lubricating fluid that might be found within that mucosal wall there. But if something else is, if any other material enters this area, a cough reflex will get stimulated. So that's where, if you take a bite of that powdered sugar donut and you inhale right when you put it towards your mouth, and it kind of pulls back into your throat a little bit, and it's going down into your airway. If it's just right up here, you're going to get a cough reflex, but it won't be terrible. We'll talk about the bad one in a second here. Now, what's right underneath here are these vocal folds. Now, another name for these are called the ventricular folds, or another name for those are also the false vocal cords. So there's true vocal cords below that, those vocal ligaments, and then there's these false vocal cords, are these ventricular or vestibular folds. These are folds for shutting off the airway, but they're not for vibrations. They don't produce phonation at all. They're just to kind of close off that airway. So you can see again from a sagittal view what we're looking at. Just underneath of these vestibular folds is a little space called a ventricle. So that's why these vestibular folds, do they name it for what's above it, the vestibule, or do they name it for what's below it, the ventricle? And some books will name it either. So just depending on what the author you're looking at has decided to say. So the vestibule and the false vocal cords here, the vestibular folds, and then the ventricle is right underneath that here. So this is the area between the false vocal cords and the true vocal cords just below that. And then there's an area below the true vocal cords here called the infraglottic cavity, or the infraglottic area. This is below the glottis, okay, below the cords. And this is an opening then into the airway. So just above, well, above this would be the vocal cords here. So if material, we talked about it, if it gets up into here, that'll stimulate a cough reflex. If it's not just, if it's air, if it's any liquid or other material, if it actually makes its way down into this infraglottic area, this is going to create an exaggerated cough reflex. The body, again, it does a fantastic job of defending itself via the vagus nerve here, because that's what stimulates all of this larynx, to get rid of any material that might have gotten below the glottis. So a very exaggerated cough reflex, and I'm sure we've all experienced that in the past too. The conus elasticus. This is just this connective tissue you can see kind of on each side here below the glottis. As it comes up, helps make these true vocal cords as they come up. This will produce vibration for vocalization and phonation and speech and all that right down here, this conus elasticus. Now, if you remember all of this, here, let's just look at this from a mid-sagittal section here. So again, the epiglottis is here. You've got the glottis, which is the opening to the larynx. And here you can see those false folds, the vestibular folds right there. And then right below that, there's a little space. That's the ventricle. So the vestibule is up here. Here's the vestibular fold. Here's the ventricle. And then the true vocal cords, or the vocal ligaments right here. And then anything under that would be that infraglottic cavity or area there. Actually, let me go back to this one. This might be a different way to see this. Here you can see, a little tougher to see because it just looks like it's shaded differently. This is kind of pinkish and this is the white. Here would be that ventricular fold from a transverse section. Above this would be the vestibule. Below this would be the ventricle. And then the white here you can see is the true vocal cords here, the vocal fold. There, the true cords here, the vocal ligaments. Okay, now if you remember, all of this area is innervated by the vagus nerve. So remember the vagus coming down here, how it's going to come back. Well, here, let's go. It kind of dives behind the carotid here, but here you can see a branch called the internal laryngeal branch. Here's a branch called the external. These are both branches off of the superior laryngeal nerve, which is off of the vagus. Internal is going to go into the glottis, and that's what's going to stimulate that cough reflex if it doesn't get below the vocal folds. If it does, and then here's that the external branch of the superior laryngeal nerve, which is a branch off the vagus. Do you get all that? Vagus, superior laryngeal. Here's internal, here's external. External is going to stimulate the motor control for the cricothyroid muscle. And that cricothyroid, remember, is going to cock the thyroid forward to produce a little tension on the cords here. So if you can get a little speech in that way. But here it comes down, the vagus is going to come down. It's going to send a loop around here. It's going to loop around the arch of the aorta on the left. And it's going to loop around the subclavian artery on the right, and it's going to come right next to the trachea and then innervate the rest. Here's that recurrent or the inferior laryngeal, which is going to innervate the rest of those laryngeal muscles that we just talked about. Okay, now let's switch gears. The last subject that we'll talk about now is the ear. Let's talk about the ear a little bit here. So from here's the outer ear is really anything from this the auricle here coming in through that external acoustic meatus, and then we're hitting the tympanic membrane, the eardrum here. Anything from the tympanic membrane out is the external ear. Anything from there towards the oval window where the stapes or the stapes comes in, I learned it as the stapes, but I'm learning it now as the stapes. You might hear me call it both, but you'll get what I'm talking about. As those middle ear ossicles will vibrate and push towards the inner ear. Now here's a whole nother section of the ear. So you got the inner ear, which contains the semicircular canals, the vestibule, and the cochlea. And then you've got the middle ear, which contains, or the sometimes called the tympanic cavity, contains the ossicles. And then here's that eustachian tube, or the pharyngotympanic, or the auditory tube coming down into the nasopharynx. Remember the torus tuberous, that cartilage rim around where that auditory opening, or the pharyngeal opening of the auditory tube is. That's going to lead right up into that middle ear cavity. And then here you've got the tympanic membrane, and then the outer ear this way. So what you can do, well, here, from the middle ear, the things that we might be able to identify today, these ossicles, the malleus is here. This is the first one connecting to the tympanic membrane. The incus is the next one. That's what the malleus is pushing into. And then the incus pushes into the stapes right here. And then that is going to be like a plunger pushing into the inner ear cavity here. And we might be able to find some of this today. Now, this dissection is optional. We don't need to spend a lot of time doing this, but if you'd like to, you can take some time and look at this. Now, this is a view from the top down in the skull that we've removed the brain already. And here's that petrous portion of the temporal bone, that ridge of bone. Here you can see where the semicircular canals and the cochlea would be. If you follow this back a little bit, kind of in the front of this petrous portion is going to be this middle ear cavity, where we might be able to find the malleus, incus, and stapes here. If you look too high, you'll open up the inner ear cavity, and we can do that too, but if you're looking for those middle ear ossicles, you want to look a little more in the front and a little more laterally here. Notice here too how the ear is coming in this direction. Here's the external acoustic meatus pushing this way, right? It comes actually at an angle from lateral to medial, from posterior to anterior. And if you've ever put on a pair of stethoscopes, you found that by pushing those ear pieces a bit forward, you're able to hear what the stethoscope is pushing out much more clearly. So that just gives you an idea of where that canal is aiming. Lateral to medial, posterior to anterior, so kind of get that idea. Let's see here. If I go to this view, oh, here. So, like I said, you might be able just to kind of take a chisel, just very lightly. This is pretty thin. Be careful not to just whack it and lose everything, but you might be able to break this open, this bony part here, and identify some of those. Now, usually we can find a malleus. Usually we can find an incus. The stapes is a bit of a tough one. I found that only once in a while can we find the stapes. So if you do find that, we'll call everybody over and and celebrate with you. Let's go to this shot here. This is looking at it, if you can get your view here, you're looking at it from the middle ear cavity from the inside looking out. So here's the incus and the malleus, and then that's going into the tympanic membrane, which out from here into the screen would be that the external acoustic meatus. And then here you're looking at it from the inside. So here you can see where the incus would be pushing against the stapes. Here's the stapes pushing into that oval window, pushing into the inner ear cavity. So we're looking from the outside looking in, we're looking from the inside looking out. Hopefully you can get that view here. But here I want you to take a look at this mastoid portion. Remember the mastoid process back here? This is of that temporal bone. It's very spongy looking bone here. As the bone grows during your development, these compartments made by this bone can grow too, and even be connected into this middle ear cavity, and that can create mastoiditis. I think we touched on that a little bit earlier, but just to kind of see that from a different perspective now. So an inner ear infection that may have come up from that auditory or eustachian tube or the pharyngotympanic tube coming from the nasal cavity, especially in young children. That tube is much more flat. It doesn't have as big of a pitch. As the head grows, as you develop, that pitch is going to get much more steep, and the chance of an infection coming from the nasal cavity into the middle ear is much less likely. But you can see how an infection in the middle ear can enter this mastoid bone and create some infection into that into those pockets there of bone, the mastoiditis. Here you can also see that carotid canal. Remember, look how close this is to that middle ear cavity. We talked about this when we saw the vasculature of the brain going through the skull. And we talked about how sometimes if you're in a very quiet place, like in the woods in the wintertime, sometimes the sound is dampened by the snow, and sometimes you can hear your pulse. Or maybe if you're going to sleep at night and it's very quiet and your head's on the pillow and you hear your pulse, sometimes it's really loud. It feels like it's really loud. Everybody can hear it. It's really just because it's very close to your middle ear cavity, which is a place where you create sound, or sound gets conducted. So very easily found there. So the carotid canal being right there. Now also on this picture here, you can see the facial nerve coming down here, but here's the chorda tympani nerve. And you can see how that kind of winds itself, that branch off of the facial nerve. It kind of winds itself through that middle ear cavity, and then exits the petrous portion of the temporal bone here, but that facial nerve continues. Here you can see it looking from the outside in. You can see how that facial nerve is going to kind of come back around here and exit through the stylomastoid foramen that way. So we touched a little bit earlier too on Bell's palsy. Remember that? How if there's an over-ossification of the mastoid area, that can kind of entrap or grow around that facial nerve, and you can get some palsy issues, some facial muscle paralysis by that nerve not conducting its signal quite as well. Also in this picture, this is interesting, I think, a couple of muscles in here. I think that's kind of weird. In the middle ear cavity, a couple of muscles that help to dampen loud noise. Now, not the loud noise that you get from popping a balloon or sneaking up on somebody and yelling, or like a shotgun if you're hunting in the woods. That sudden loud noise, that's not going to protect. These aren't going to protect you from that, but rather, like if you go to a loud concert or mowing the yard, or maybe your roommate snores really loud. There's a kind of a steady noise, that loud noise. There's a couple muscles here. This one's called the tensor tympani muscle. This one's going to attach to the malleus right there. And there's another one, if we look on the inside here, you can just see the tendon of a muscle called the stapedius, which is the stapedius muscle here attaches to the stapes, and these will limit the movements of those inner ear ossicles and guard against any damage from excessive kind of prolonged noise. You get that there. Maybe some of you have had tubes in your ears. I think that's called, I'd have to confirm this. I probably shouldn't talk without looking this up, but tympanostomy, I think that's called. If you get tubes in your ears, sometimes the kids are highly prone for middle ear infections. They can get these small, tiny tubes kind of fit on the end of a safety pin. Think of really small that can be placed they pierce the tympanic membrane to help kind of drain the middle ear for chronic, kind of chronic ear infections. And if you do this, you want to place them low on the tympanic membrane, quite low, for a couple of reasons. One, if there's an infection here, you want to put it at the low spot. That's going to help drain more fluid that might have accumulated in that middle ear. And also, look what's above that. You got the ossicles here, but also that chorda tympani. You don't want to damage the chorda tympani, this part of the facial nerve that joins in with the that joins in with the lingual nerve for that taste sensation here. So you want to put that low because that chorda tympani goes quite high on the tympanic membrane as well. A couple other things here. The fenestra vestibuli. I don't know if I have a better shot than... Well, here, this is a decent shot too. The fenestra vestibuli, also called the vestibular window, also called the oval window. This is kind of where the foot plate of the stapes is going to push into the inner ear. Okay, and that's going to transmit the vibration from the tympanic membrane through the malleus, through the incus, through the stapes, into that vestibule. That's going to help to kind of move that fluid into the cochlea. And that vibration is going to go through that 2 3/4 turn organ called the cochlea. And then it's going to exit right here through the fenestra cochlea, or another name for that is the cochlear window or the round window. So you got the oval window where the stapes pushes in, and then the round window is down here. This is going to allow movement of the fluid within the cochlea to kind of have a place to bulge out. So as the oval window pushes in, this is a closed space, right? So then there's got to be pressure pushing out through that round window back into the middle ear cavity. There, okay? So that's where those oval and round windows are. On the inner ear, let's see. Let me go to this one. You can see a little bit different. Here's the oval window. Can't really see it. It's just underneath where the facial canal is here, that facial nerve. And then the round window is kind of placed right back here. So going into and then pushing from the inner ear cavity. Okay, now the inner ear. Let's just talk about this quick. A couple things on this. So this, again, let me go back up to this slide. This is more medial along that petrous portion within the skull. Again, you can break this open and kind of try to find some of these structures if you'd like. But the things you might find here are these semicircular canals are going to be more on the back side, and then more toward the front is going to be the cochlea here. The semicircular canals, you can see this is kind of like an internal gyroscope within the inner ear. These are 3 perpendicular loops, all at right angles to each other. So you can see how one is going to come and go this way, one is going to go more on a transverse plane, one's going to go more on a coronal plane. So they're all in 3 planes of movement because we're in 3 dimensions. The 3 planes, sagittal, coronal, and transverse planes, that's what these loops are going to be on, the semicircular canals. And they allow us to feel what's happening in all 3 of these planes here. Now at the ends of those, here you can see the ampulla right here. This is a little kind of a distended portion here, here, and here. It'd be here, here, and here. And again, from a kind of a back view, here's the ampulla, ampulla, and ampulla. Let's move to this shot here. Here's a kind of a close-up view of one of the semicircular canals. And then here's that ampulla, this distended portion on the back side here, kind of a bulge at each of the ends of the semicircular canals. And these have hair cells here. These crista ampullaris is this whole structure here with hair cells that act as receptors, and they're covered by this gelatinous mound called a cupula. Okay, so as the endolymph, which is what's inside of these semicircular canals, kind of moving as our head moves in each of these planes, as that moves around, it's going to push at the ends of these semicircular canals, and will bend. It will push on the cupula, which will bend these hair follicles, which will cause an ion transfer in the hair follicles, a depolarization, an action potential to go along that vestibular portion of the vestibular cochlear nerve, cranial nerve number 8. And that's where we get some of our brain will get the information involving dynamic movement and balance. So in each of these canals, one will be more for the sagittal plane, one will be more for the coronal plane, one will be more for the transverse plane. Are you shaking your head no? Are you nodding your head yes? Are you tipping your head side to side? The fluid within those perspective, or those canals, respectively, whichever one you're moving your head in, will move the cupula within the ampulla, stimulate these hair follicles, that crista ampullaris, and tell that the nerve will then tell the brain, hey, we moved from here to here in this direction at this speed at this time. It's real time information regarding dynamic balance. Okay, now, so here you can see those three semicircular canals. In front of that now, in front of these ampullas is this region right here. Remember, here's that oval window, the fenestra vestibuli, where that stapes is going to push into. It's going to go into this vestibule. Well, there's a couple of other organs here. Here, here's another view of this. Take a look at this. Here's an actual scanning electron micrograph of a ampulla of a semicircular canal. Here's that cupula, that gelatinous mound that covers the crista ampullaris, and then this whole canal would be filled with a fluid called endolymph. So that's what that is here. But going back to that vestibule, here is a couple of other between the semicircular canals and the cochlea here, a couple other organs. One's called a utricle and one's called a saccule. I did not make this up. I do think I would have chosen those names though, because they are pretty cool. These are otolith organs. Okay, now here's a kind of a close-up view of what that looks like. These are, again, hair-sensitive cells that will help to kind of determine if they bend in a certain direction. That will help the brain to know what's happening. Now, when you bend forward, they'll depolarize and stimulate the nerve, and that gets translated into a particular direction. But again, just like in the ampulla with that with the semicircular canals, these hair cells are covered by a gelatinous mass, again, giving it kind of just this weight to it. But to really add to that are all of these calcium carbonate crystals here, sometimes called otolith crystals, that sit on top of that gelatinous mass, that give it kind of mass. They give it kind of some density, so that when it bends, they're very sensitive to gravity, is what these will do. So they'll alert the brain about information involving static movement and balance. So semicircular canals, dynamic movement in the vestibule with the utricle and the saccule. These are going to be more for static balance. So you can see here's just a different view. This person sitting level, neutral, eyes are flat. The hair cells are here. Here's that gelatinous mass, that membrane, covered by those calcium carbonate otolith crystals sitting on top. But as this person bends their head forward, that's going to push. This whole gelatinous mass is going to just push forward like this. And because it has mass, because of those crystals, it's going to pull and bend those hair follicles, creating that depolarization, again, in the vestibular portion of the vestibular cochlear nerve. And that's going to give your body the sense that your head changed position, even though you might not be moving dynamically. This is more static balance. Okay, so balance, if you consider balance as, I learned it as like a three-legged table, as something where the three legs would be vision, is a third of your balance. If your eyes are closed, you lose some. You try to stand on one foot with your eyes closed. It's very difficult. So vision is a third of balance. The surface you're standing on, if you stand on with 2 feet in shoes on concrete, it's very solid, very predictable, good balance there. But if you stood on bare feet on a beach, or maybe on a pillow or a quilt or a stack of blankets, creating a little bit of unsteady surface that you can contact the earth with, that's going to be difficult to balance. And then your head position. All these things were moving here. So the dynamic and static balance receptors of the inner ear are going to be the third leg. So vision, the surface, and head position all contribute equally to balance. And then we can mess with balance clinically by changing any of those variables there. Tough to change the variables of the inner ear, but we can certainly change your eyes and the surface that you're connecting to the earth with. One of the most common causes of uh, uh, dizziness, or called vertigo, is called benign proximal positional vertigo. And that gets triggered with specific changes in head position when these calcium carbonate crystals can get kind of dislodged. Think of a cupcake, a frosted cupcake with sprinkles on it. And you would tip it upside down over a countertop, and many of the jimmies, the sprinkles will get stuck. They're stuck in the frosting, right? But every once in a while, if that frosting dries out a little bit, or if you hit it a little, if you kind of shake the cupcake, this is a weird analogy. Sorry. Every once in a while, some of those sprinkles, those jimmies, will fall off onto the counter. If that happens, if these otolith crystals fall off, what can happen is they'll get dislodged back up into maybe one of the semicircular canals. And then that endolymph, every time you move dynamically, if you were to look up and to the right or up and to the left, this happens a lot with BPPV, that benign proximal positional vertigo, where patients will talk about how they followed a plane, or they're following a flock of birds across the sky, and all of a sudden they have this debilitating dizziness. And that's because the fluid in there, if you put a rock in here, it's almost like a tidal wave. And now it's really going to it's really going to push fast and hard against that cupula, really giving the brain a sensation that we are out of control. We are moving way too far. People will fall off of the chairs that they're sitting on. It is a debilitating problem. But actually, sometimes it's quite easy to fix. Sometimes, not every time. There are therapists that are trained for this, particularly vestibular therapists. But you can really kind of take the head in certain positions and move it around to get that otolith crystal to kind of fall back into the vestibule where it belongs. And that vertigo symptoms can sometimes be relieved quite simply. Not always. If not, I would go seek a vestibular therapist's counsel. Oh my gosh, that's all the information I want to talk about. Hey, I just want to say I have really enjoyed this time that we spent together for this course. I hope this is an experience that's been a great one for you. I hope you've just had a really good time learning this. I hope you've the things that you've learned, not only the anatomy, but also just the skills you've learned, and you've honed your dissection skills, your identification skills on these structures. I hope that what you've learned here will serve you well as you move from here. Dissecting the human form is a really unique experience, one not to be taken for granted, and it's not for everybody. But I believe it is holy ground that we've been stepping on here, and I'm so thankful to have had the opportunity to work alongside of you during this process. Thank you for trusting me. I wish you every success as you move on to your next. We've got one more test. You've got this. I look forward to seeing you in lab. Thanks for your time.